Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is ventilation. So there's two key types of ventilation, invasive and non-invasive. If we look at invasive forms of ventilation first, this requires intubation and by definition therefore requires level 3 care on a critical care environment. Non-invasive forms of ventilation include CPAP and BIPAP, and we will talk about these in greater depth in the presentation. So firstly, non-invasive ventilation, as we've said, can be divided into two types, CPAP and BIPAP. The first form is CPAP, which is continuous positive pressure ventilation. This is delivered through a tightly fitted mask and provides pneumatic splint to the airway. It is the treatment of choice for obstructive sleep apnea, as well as pulmonary edema in the context of heart failure. It's important to measure one's blood pressure as the rise in intrathoracic pressure inhibiting venous return may lead to a reduced cardiac output. It's also really important to discuss these patients with the intensive care unit early with regards to escalation of care. The second form of non-invasive ventilation is biphasic positive airway pressure or BiPAP. This provides oxygenation and helps to correct hypercapnia or high levels of CO2. So for example, this may be in the context of COPD. COPD is one indication, but other indications in the presence of type 2 respiratory failure include paralysis of respiratory muscles, such as that seen in Guillain-Barré syndrome or motor neuron disease, as well as severe chest wall deformities. Due to the underlying hypercapnia, it's really important to monitor arterial blood gases regularly. As the patient improves, so does the time off the ventilator. Again, it's important to discuss these patients with ICU early with regards to escalation of care. And here we just have a summary slide to summarise what we have just been discussing and can provide a good aid memoir for the key principles of both CPAP and BiPAP. So now let's do a question. A 65-year-old man with a BMI of 35 presents to the respiratory outpatient clinic with a 3-month history of fatigue and somnolence. His partner also mentions he is snoring through the night. Given the likely diagnosis, which of the following statements is incorrect? So our choices are: he must inform the DVLA about his condition, Epworth Sleep Scale is indicated, polysomnography is the gold standard test of choice, he might require treatment with BiPAP, he should be assessed for other risk factors of metabolic syndrome. So the incorrect answer here is D, because he does not require treatment with BiPAP. It is in fact CPAP that is used for OSA, which is the likely diagnosis in this case. If you would like more information about OSA, then please check out our previous YouTube video on obstructive sleep apnea, which can be found here. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.